and welcome to Medical Dialogues. I am Dr. Nandita Mohan. Today, I will be taking you all to explore the world of rare diseases, and my topic for today is C3 Glomerulopathy, which is a dense deposit disease, and C3 Glomerulonephritis. Now, to help us understand in detail, in depth, we have with us today Dr. Anil Kumar BT, who is the HOD and Senior Consultant, nephrologist, and a transplant physician currently in Bangalore. Beyond being a seasoned, Dr. Anil is a beacon of empathy, bringing a wealth of expertise and heartfelt commitment to nurturing kidney health. Now, he has performed the highest number of deceased donor kidney transplants in a single quaternary care center and has also performed highest number of ABO incompatible and paired exchange transplants in a single center in Karnataka. So, welcome to Medical Dialogue, sir. It's really a privilege to be having you on board here with us today.
Hi, everyone. Thanks, Medical Dialogues, for giving me this opportunity to talk a few things about this rare disease, this C3 Glomerulopathy. I'll start the presentation.
Yes, sir.
Complement C3 glomerulopathies. These are diseases of the kidney wherein the kidney filters, that is the glomeruli. Mainly kidneys contains three things: glomeruli, tubules, and vessels. In that, the kidney filters, which are also called as glomeruli, are damaged due to some abnormal activity of the complement proteins which are present in our body. And this includes two types of subforms actually in the C3 glomerulopathies. That is, one is dense deposit disease and C3 glomerulonephritis. It is also called as C3GN. Dense deposit disease, we also term it as DDD. And these are rare forms which are seen both in children and in adults. So going back to the history, like how this terminology came. So previously we were not calling this as C3 glomerulopathies. We were calling it as membranoproliferative glomerulonephritis. In the early 60s, actually, all this glomerulonephritis, the inflammation of these kidney filters, what was called as Bright's disease actually in 1960s. So later onwards, in a meeting, they termed one subgroup of this Bright's disease as MPGN, that is membranoproliferative glomerulonephritis. And because in this there was a constellation of features like nephrotic syndrome, blood in the urine, that is hematuria, kidney function deterioration, and subsequently in 1965, a scientist named Clark West. So he described that some of in the immune system, the deficiency of the complement was responsible for this MPGN. And later onwards, this term membranoproliferative glomerulonephritis was coined. Basically, this terminology was coined by seeing the biopsy findings, the kidney biopsy findings. In the kidney biopsy, there were three types actually: type 1, type 2, and type 3. If you see in this picture over here, so this is the ultra structure of the one of the glomeruli, one of the filters of the kidney. So where there is the capillary loop, there are small blood vessels there. We call them as capillaries. So in these capillaries, we have a layer called as endothelium. So if these deposits are present within the capillary, like within the endothelial wall, we tell subendothelial deposits. They are termed MPGN type 1. It is within the membrane, then it is called as type 2, that is inside the membrane. And outside the membrane or inside the membrane, we term it as type 3. So later onwards, so more and more knowledge came to know, and there were several subcategories of this disease. Each type was subcategories was behaving in a different manner actually clinically. So then with the like in a biopsy, whenever we do a biopsy for any kidney biopsy, we do a light microscopy, electron microscopy, and immunofluorescence. Based on immunofluorescence, they found that some of the diseases where there were only C3 deposits and some with the immunoglobulin deposits were there. So if there are only C3, the complement C3 deposits. So they were called as C3 glomerulopathies. And if there was associated immunoglobulin deposits also, they were called either MPG, infectious glomerulonephritis, or other varieties of you see in SLE. So these they were divided into other categories. So now, what was the earlier? Broadly we used to call them as membranoproliferative glomerulonephritis. Now, based on immunofluorescence, if there is only C3 deposits, we call them C3 glomerulopathy. And today, what we are talking about is C3 glomerulopathy. In them, there we have two subcategories of disease. One is dense deposit disease and C3 glomerulonephritis. So, for to say briefly, so to diagnose this type of diseases, we needed to do a kidney biopsy. The biopsy in the light microscopy, it shows membranoproliferative glomerulonephritis. When you do a immunofluorescence, so that is a special apparatus we used to see what are the deposits. So if there are only C3 deposits, we see C3 glomerulopathy. If there are immunoglobulins as well, it may be because of infections, some malignancies, or some autoimmune disease like SLE. So, coming to how common are these diseases, what is the epidemiology of C3 glomerulopathies? It is a rare disease. So, about in 10 lakh people, we may see around 2 to 3 cases. Such rare is the C3 glomerulopathies. It is common both in children as well as young adults. Males and females are equally affected actually, and it is a compared to other glomerulonephritis, it progresses very slowly. Majority of the diseases, there are some diseases which may progress very fastly, but it progresses over 10 years. And in 80% of the children, within 10 years after you diagnose, they reach end stage kidney disease. That is stage where a patient requires dialysis or transplantation. Whereas in adults, within 50% of them, like within 10 years of diagnosis, they reach end stage kidney disease requiring dialysis or transplantation. And what happens if we do transplantation for these patients? So the kidney again fails and the graft is lost. It happens in almost 50% of the cases within 10 years after the transplantation. So why, we need etiology. People ask us why this disease developed actually. So basically, in our immune system, complement is an important part. So there is an alternative pathway, a classical pathway. So there is some developmental or acquired abnormalities in this complement system, so which is causing this kidney disease actually. So to know more about this one, first and all, we should know what is our immune system actually. So in our human body, we have two types of immune system types actually. So one is acquired immunity and innate immunity. So what is important is to like what is innate immunity is all of us will have this one and it is continuously active. So acquired immunity is like you develop a fever, it may be a malaria or a dengue fever. So there will be some antigens or some virus infection. So then there is some T cells and B cells in the blood. They will become active. So they will produce some cytotoxic cells which will cause death of that infection. Otherwise, B cells are activated. There will be formation of some antibodies. They will kill these antigens or viruses through some special complement system which is activated. Whereas in innate system, like we have this continuously it is active in our body. Like for example, we have some barriers. Like so, we our skin protects actually. In the mouth, we have some mucous membranes. The saliva has got antibacterial facilities. In the stomachs, we have some acid secretion. They also protect from some of the bad infections which may come through food actually. These are all physical barriers actually. The same time, in the blood, we have this complement system, which is the topic of our discussion. So they also are very important parts actually. So where they may either cause direct killing of bacteria or they may produce these natural killer cells in the body. So this system of complement system, they complement the body immune system to fight against the germs or virus or bacteria actually. So they play a very important role. So this is how the complement system, there are three types. So what is important in this disease what we are talking today is the alternative pathway. So they get hyperactivated and causes more destruction in the body actually. So to how this happens is, so this system, whenever normally what happens is it is very controlled actually. So there are some regulators which will control this complement system. Whereas in C3 glomerulopathy, so there is it becomes abnormally activated actually. And because of this some breakdown products are formed which will get lodged in the kidney, and they are responsible for the kidney disease. Once again, so as I told, this is the alternative pathway of the complement. There are some controlling factors actually. So what happens in this disease, sorry, so what happens in this disease is this regulators either they get mutated, or there is a deficiency of this one, or there are some abnormal proteins called as autoantibodies which develop this responsible for the kidney disease. So this is a diagram showing, so what are the causes why this pathway gets becomes abnormally active. It may be either because of genetic causes, which is responsible in 21% of the cases, or there may be some autoantibodies in the body, like which is 50 to 80% cases there are C3 nephritic factors. So they what they do is nephritic, they activate this C3 convertase or C5 convertase, so that this becomes continuously activated, and we form a membrane at a complex which will damage the cells actually. And also the byproducts are deposited in the kidney, responsible for the kidney problems. So what happens now, I have told about the what are the causes and what is the pathogenesis. Coming to the features of like how they present to us, how these children or adults present to us. So commonly the symptoms are they come with blood in the urine, or some protein excretion in the urine. If there is protein in the urine, what happens? The child or the adult will have swelling of the feet, hand, or ankles. And sometimes, if the disease is very severe, they will have a reduced the glomerular the filter function will also get reduced, and there will be increased blood urea and creatinine. That is what we call as kidney function will get reduced, and kidney failure develops actually. And they may have lot of tiredness. And also if you check in the blood, there may be some of these antibodies called as C3 nephritic factor, which is seen in 80% of the patients with the dense deposit disease, and around 40% in C3 glomerulonephritis. Both this DDD and C3 glomerulopathies are part of C3 glomerulopathy. So there are some extrarenal manifestations, not only pertaining to the kidney. If you see in some of them, we tell acquired partial lipodystrophy. So this is especially seen in this dense deposit disease. So what happens is in the upper half of the trunk, actually, including face and this thing, the adipose tissue or the fat tissue, they will become atrophied actually. So that what happens is if you see the chins and the cheek and all, so you will hardly see any fat actually. We'll tell lipodystrophy actually. This is how they look actually. And sometimes it is surprising before the kidney disease happens also. So you may develop this lipodystrophy. So it is very interesting actually. And also if you see in the eyes, so they also there will be some deposits in the retina. This is the fundus examination, means in the retina what we see. So there patient have this deposit called as, we call them as drusen actually. So these are deposit which we see in the there is a membrane called as brush membrane in the retina. So the same deposits also will be developing in the kidney. The same deposits are developed in the deposited in the retinal brush membrane actually. So we tell is drusen actually. So how to diagnose this patient who is having C3 glomerulopathy? So what I told, because this is a problem of the alternate complement pathway, which is a part of the immune system. So you need to see what are the functional assays which is concerning to the complement. So we have this commonly what we do is C3 and C4 level. In many of the some of the bigger laboratories, we do factor IEH and all these things. So if C3 or C4, which is widely available in most of the diagnostic centers, so if they are low, we suspect this patient is having complement C3 glomerulopathy actually. So we also can measure autoantibodies like factor H autoantibodies, B antibodies, and nephritic factors. So this will tell that what is the whether it is if they are present, then it is autoantibodies, and if all these things are negative, then we can do genetic testing. So which we many of the laboratories do. So we get the test report within 3 weeks actually. If they are present, which is seen in around 20 to 25%, so we make a diagnosis of C3 glomerulopathy. If you if a patient who is more than 50 years develop this disease, we have to suspect some of these diseases called as paraprotein associated disease like multiple myeloma, which is a we can tell bone malignancy or a bone cancer, which is also called as multiple myeloma. So where we can do this some test called as electrophoresis. So if you diagnose early, if you treat that disease, the multiple myeloma, the C3 glomerulopathy can be cured actually. So ultimately, most important test to diagnose this kidney disease is kidney biopsy. So as I told in my first few slides, so if you do a light microscopy, the biopsy will look like in the lobules, like small in the glomerulus filter. And later, second part, we should do immunofluorescence. In the immunofluorescence, this is how immunofluorescence looks. So we see the strong C3 deposits actually. So see, the only C3 deposits means we tell C3 glomerulopathy. So where they are, if you do electron microscopy, this is an ultra microscopy where the deposits are there. If they are in within the membrane, we tell dense deposit disease. If they are outside the membrane, deposits are there, we tell C3 glomerulonephritis. So now the final part of the topic is how you manage these patients with the C3 glomerulopathy. If a patient, usually they present with proteins and in the urine, they may present with swelling of the feet, they may present with blood in the urine. So for the management, what is important is if a patient presents with a proteinuria, that is protein excretion in the urine, which is more than 1 gram per day, so you need to start a supportive care. The supportive care includes antihypertensive medications like AC inhibitors or ARBs. So these drugs, they reduce the proteins excretion in the urine and thereby slow down the progression of this kidney disease. So we need to titrate this dose such that we target the systolic BP less than 120 millimeters of mercury. And if the protein reduces to less than 1 gram, so no additional treatment is required. But if there is the worsening of the proteinuria, and also there is more blood in the urine, and also if there is declining kidney functions, if the creatinine is increasing, then we need to consider giving the treatment, that is corticosteroids and other immunosuppressive medications like mycophenolate mofetil. So corticosteroids, we need to give for around 3 to 6 months. So if there is no response even with this treatment, then on major like around 40% of the cases there will be no responses with this treatment. So then we need to consider these rare drugs which is not available in India on case to base basis, that is called as eculizumab actually. So in our this thing, we don't have this drug. We usually import it on a black market, if at all it is there essential, and they are very very expensive. It may be cost around like we have to give this drug every week for throughout life actually, and each injection will cost, each dose for 1 week, which in the year it will cost around 6 to 9 lakh rupees. So it is very essential, very costly, and it is not available also in India as of now. We need to import it in a black market, and only things. So sometimes we can this thing. So on if you are enrolling these patients on a trial, so on so humanitarian grounds, they may send this medication. Otherwise, it is very difficult actually. And in spite of that, actually, though, if you use this drug actually, so in the earlier it was thought that there would be a complete response, but now so many studies have shown that the response also is around 33% to 40% actually. So like this was a study of the one trial which was published in American Journal of Kidney Disease in 2018, and it was shows only 6 of the 26 patients showed complete remission, and one showed partial remission. So it is very difficult to tell at this point this drug, even though it is costly, even though if it is becomes available, so it may cure this disease. It is not at this point we can't tell that this drug is going to cure the disease. So now with more and more knowledge about the complement pathway, we there are a lot of trials now are in progress. So they have initially, as I told, eculizumab was the drug actually. They targeted at this site where the C5 convertase enzyme, where it causes the terminal pathway, what we tell, where the membrane attack complex is there. So subsequently now there are other drugs like C5a receptor, evocopan, and peglet, like the upper part of the upstream when they targeted the C3 itself, which is called as pegcetoplan. So this is another drug. And also we have drugs against factor D, that is dinacoplan. And recently, within a year now, one more drug called as iptacopan, which targets the factor B, came into the market actually, and it has shown, it is a oral tablet, and which has shown to have some promise in patients with this disease, C3 glomerulopathy. More than 40% to 50% showed reduction in the proteinuria, and they have used even after transplantation in a couple of studies. So these are the trials, ongoing trials, which are now this thing. So recently, FDA approved iptacopan and also pegcetacoplan. There is an approval for this drug to be considered to use in patients with C3 glomerulopathy. So, in conclusion, C3 glomerulopathy is a rare disease resulting from dysregulated alternate pathway of the complement system. Presentation is quite variable. So, most often they present with proteinuria, hematuria, and declining renal function. And for the diagnosis, kidney biopsy is necessary to confirm. The natural history varies with the overall poor prognosis, because at least more than 50% within 10 years they reach end stage kidney disease in adults, and 80% in children. And even if you do transplantation for these individuals, there is a high rate of recurrence after transplantation. At least 50% will again develop this disease and kidney will fail. And we don't have high evidence for treating this disease as well with steroids and MMF currently, which is currently recommended for moderate to severe disease. Terminal complement pathway, which I told, eculizumab, so it is anti-C5 therapy, is reserved for unresponsive kidneys, and also the efficacy is very modest. It is around 40% may respond. And of course, there is a lot of light at the end of the tunnel. So we have multiple trials going on for this disease, and proximal complement pathway, which I prescribed, I told in my previous slides, like iptacopan and pegcetacoplan, which are showing some promising results, and they are ongoing. Hope one day we find a treatment for this rare disease, which is a bad disease and prognosis is very poor. So thank you. I will be happy if you can post any questions. Thank you.
Thank you so much, Dr. Anil, for joining us today at Medical Dialogues and giving us this wonderful insight about this rare disease, so that more and more people can actually come to identify that early, keeping the symptoms and the signs in mind. So thank you so much once again for joining us today.
Thank you.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.